You're tuning into the Active Mom Podcast with physical therapist, Dr. Carrie Pagliano, a real mom's guide to all things postpartum return to workouts after baby. If you're a postpartum mom, coach, trainer, or physical therapist looking for answers on how to get back to running, CrossFit, yoga, Pilates, HIIT, you name it, without the fear of pelvic floor issues or doing something wrong, this is the podcast for you. Let's start the show. All right, I am super excited to have our next guest, Jenny LaCross. I have known her, since she was a resident after PT school, and just been super fun following her through her PhD journey and as a clinician. And I'm a super fan of anybody that can do research and be a clinician and kind of like do all the things. She's played in constipation and hips, and now she's got some papers out on birth injuries. So we're going to have a whole lot of fun talking about everything today. So Jenny LaCross, welcome to the Active Mom Postpartum Podcast.
Thank you so much for having me, Carrie. It's a real honor and pleasure to be here.
Super excited. So tell us a quick little bit about who you are, where you're from, all that good stuff.
Yeah, so my name's Jenny LaCross. I'm originally from St. Louis, Missouri, currently reside in Ann Arbor, Michigan, and have lived in numerous places in the interim, kind of across the country. I think the Pacific Northwest and, like the far Northeast are the only two places I haven't lived. I graduated from PT school knowing that I wanted to go into pelvic health. So like you said, that's how we met. I did my residency at UPMC Centers for Rehab Services. Due to my husband's job, who's an athletic trainer, he worked in D1 football for a decade. We moved around a lot, hence I moved around a lot. Was a practitioner in Texas and in Oklahoma, and just kept seeing things in my practice. And I'd go to the literature to try to find answers, and I couldn't find any. And I got very frustrated, and I thought, why is there no research on this, or why is there very minimal research on this? So instead of just saying, well, I'm just going to, throw spaghetti at the wall and hope something works for the rest of my career, I decided, well, why don't I go get a PhD and then I'm going to do the research on this, which I wouldn't recommend for everybody. But it's been quite the journey. I finished my PhD in 2023, studying hip dysplasia, so a non-arthritic hip pain condition that predominantly affects females and young active females, which is what drew me to that area. And now I'm currently completing a postdoctoral research fellowship at University of Michigan with the Pelvic Floor Research Group. And my work has really kind of focused in on birth injury and specifically prolapse, and then what that looks like for birthing people across the lifespan. And then I guess on the side, I am also still a clinician. I work at Move Physical Therapy in Monroe, Michigan. On the weekends, it is out of Light the Fire CrossFit. And so just a little shout out to my clinic. I think continuing to provide clinical care really helps me to root my research in meaningful questions, keeping the end user or the end effector of my research at the heart of what I'm doing.
And that's one of my favorite things about you, I think, and knowing kind of your roots in clinical care and who your mentors were and that sort of thing. It's so cool and ballsy, quite honestly, of you to be like, oh, let me just go get a PhD, which is no small thing, because you're like, okay, I need some answers. And if nobody else is going to provide them, I'm going to go get them myself. And so there's a special place in my heart for people like you, because I'm not going to do it.
In full transparency, and I think especially on this podcast, it's important to note that I don't have children. And so that does free up time for me, and I don't have those particular constraints. That's not to say that I don't have other things in my life that take up time, but I certainly, in working with parents for a decade, I appreciate what that time commitment is. Yeah. And I also appreciate that I don't have those time constraints. So I think deciding to get a PhD might have looked very different if I had other obligations in my life.
Or unless you're Christina Prevett, who knows?
Right. She's a unicorn.
She is. And that's why I also love her dearly, because I'm like, go girl, you keep doing it. All right. So recently, I guess a couple of weeks ago, we posted on a reel, one of your most recent studies that you participated in, looking at pelvic floor injury during vaginal birth is life-altering and preventable, and what can we do about it? And we got a lot of comments on it. So I was wondering if we could first kind of do sort of a brief overview. And I want you to pull out some of the big takeaways that we should take, not only as kind of pelvic floor clinicians, and where we may say some things or make some claims that may not necessarily be backed up, but then also kind of to our moms in the audience that are looking for kind of, I don't know, maybe some more understanding of what we can and can't prevent in the context of kind of birth. So that's not a small question at all. So yeah, let's just dive in.
Let me first acknowledge the team that was on this paper. This was an expert review paper. And so for the non-scientists or academicians that are listening to this podcast, this was an invited expert review, which means that we were gathering the evidence on this topic. This is not an opinion piece. And so some of the comments that I saw on social media are based on personal experience or opinion, and that is not to invalidate personal experience or opinion. But if you're thinking about the context of the paper, it is pulling from what was available in the literature and the highest quality of evidence that we could pull from in the literature without this being a systematic review, meaning that we had very set search terms, we went to very specific databases, we put in those search terms, and then just used the papers that came up from that. So that's called a systematic review. That is not what we did. But an expert review is also not an opinion paper.
Right.
And so I just want to...
The other thing I love Jenny for is she takes complex research terms and she simplifies it, because when you are looking at research, all research is not created equal. There, like she said, opinion pieces, we've got expert, we've got systematic reviews, and there's also predatory journals, which all their stuff is crap. So thank you for taking that and simplifying it. Also for the clinicians that may not have gotten that in their research class in PT school.
And so, one of the comments I saw was, the inclusivity of OT in this space. Rebecca Seagraves, Jenna Seagraves, there's a lot of people doing some great work in this space. Predominantly, it seems like clinically, and I could be wrong, so don't throw stones at me. I'm not an expert in this area, but it seems like there's a lot of work being done in the acute care, immediate postpartum space. Mm-hmm. However, there's no research that is out on the utilization of OTs yet in this space, which is why they were not included in the review. So it was not an attempt to be exclusionary. Again, we were just pulling what is available in the literature. Mm-hmm. So I just want to make that side note to say that clinically, we absolutely are including OTs. I think I saw, midwives at University of Michigan. There's a huge midwifery center. There's a ton of research. Lisa Kane Lowe is one of the researchers that's kind of leading this work. So you are not being forgotten or discluded. Again, it's just thinking, if we're coming back to what the scope of this article was, that's why we included the practitioners and the articles that we did.
Yeah. And I think that's a very good point. I do see a lot of, and this could be a whole separate podcast, I do see a lot more when we're talking about, pelvic floor practitioners, people are now going PT/OT. I have some concerns about that because of Practice X and things like that, and scope of practice. But to your point, what we're pulling for this particular conversation is what's currently in the literature. And, these conversations are to be continued. I do think there's a lot of opportunity to talk about other providers in this acute care space and so on. But for the purposes and also I think you said something about inclusivity. There's a lot of kind of verbiage lately about people like, oh, let's be inclusive of other providers. And it gets crossed with DEI. And I think that's not appropriate. So and again, I could do a whole nother podcast on this. So thank you for clarifying. We're not being exclusive. This is what the data is. This is what the paper is focused on. This is the expert review for those of you having questions.
let me now dive into your actual question. What was the paper about? What can we take away? I'm at University of Michigan. I'm a big sports fan. I'm a big football fan. So for those of you who don't know, the football stadium at University of Michigan is the Big House. It's the biggest stadium in all of college football. And it can hold more than this, but we'll say on average, there's about 110,000 people that attend a game day on Saturdays. We know that there are about 300,000 surgeries per year for pelvic floor disorders. So that's 3 big houses full of individuals or birthing individuals that have surgeries for pelvic floor disorders. And I just want you to wrap your mind around that number. I know clinicians in the pelvic health space always, and we do it in the article as well, you make this comparison to other injuries. But I just really want us to sit with the gravity of how many people pelvic floor disorders are affecting.
Yeah.
Why we need more research in this space, why we're doing more research in this space. And then thanks to President Biden and Dr. Jill Biden's new initiative, there is a couple weeks ago, they announced some new funding through ARPA-H. It's $100 million in kind of the next 2 years towards women's health funding. There's been some new directives towards the NIH to allocate more funds to women's health research across all of their institutes. So it's a very exciting time. You know, it should have happened a long time ago, but at least we're finally getting here. So it's an exciting time in pelvic health.
Yeah.
And so we know that vaginal birth is the single greatest modifiable risk factor for pelvic floor disorders. And really, when we think about pelvic floor disorders, pelvic organ prolapse is the one that's most associated with birth. And so, you know, if you really want to say, how do I avoid this? Then don't get pregnant and don't have a vaginal birth. I don't think that's a very good option. But if people are looking for, well, you know, I did all the right things, well, you can still do all the right things and still have an injury. The only way to really avoid an injury is to not do the activity.
Well, and I would almost take a step back from that too. Having had 2 C-sections and dealing with prolapse, really the only way to prevent it is to not get pregnant, because I honestly truly believe, and again, being at this 25 years, you're going to see moms that are completely floored because I have prolapse and had a C-section, not realizing the effects of, you know, carrying a kid for 9 months and tissue and genetics and all that fun stuff. So I'm even going to take a step back further and say, hey, you really want to prevent it. But again, I don't want to come at that with a fear mongering sort of thing too. That's like extreme, like, you know, extreme conversation, extreme prevention. So
absolutely. And that's certainly not what either one of us are promoting. No. You know, every woman and birthing person gets to make that decision for themselves.
Exactly.
But again, at the extreme end of the spectrum, if you don't want to have these problems, then, you know, you could say don't get pregnant. And thank you for bringing that up, because we actually know that during pregnancy in the 3rd trimester, the levator hiatus, and a hiatus is just an opening at the bottom of the pelvis. You have 2 of them. So the levator hiatus and the urogenital hiatus, they both have to stretch in order for the baby's head to come out of them. That just being pregnant, we start to see changes and, you know, in those openings. And so regardless if you push and then have a C-section, if you just have a C-section, we're going to see changes in the levator hiatus. Mm-hmm. We also see changes in the perineal body and the perineal membrane. So for those non-clinicians, that's the tissue between the vaginal opening and the anal opening. And that tissue is connective tissue. And so during birth, we can see changes in the connective tissue.
Yep.
And I do want to highlight, our research group had another paper come out this year, the hypothesis of the perineal complex. And what we're really starting to appreciate is that it's not just levator ani or pelvic floor muscle injury during birth that can lead to prolapse, but injury to any of the structures of the perineal complex or any combination of those structures can also lead to prolapse. What is the perineal complex? The perineal complex is the perineal body, the perineal membrane, the levator ani muscles, and then all of the connective tissue that holds those structures together. And so there's a really nice image in the paper that shows the perineal complex structures, but really kind of highlights the perineal membrane and perineal body, that if you have those structures and they get injured and separated during delivery, it almost creates this diastasis or split of the muscle, and you get this swinging door effect where the tissues kind of move down and out. And those tissues, like, we don't really have a way right now to identify that, so there aren't really any diagnostics. And then it's not really being addressed in surgeries, and we don't have any conservative measures to address it. The good news is we're working on it.
That's super interesting, because I think a lot of people, even some pelvic floor PTs, make this assumption that the only reason that prolapse can occur is the pelvic floor. And I love that you've your group has delineated, no, it's a complex, it's a lot of things. And I think a lot of people don't realize that about their bodies. There's a lot of duplication and reinforcement, and which is good, because if we only had one thing and it didn't work, we're kind of screwed. So it's multiple things. But I'm going to sidebar for 1 second, because I have had I had one client in the last couple of years, and then I've had a lot of people reach out recently with prolapse without, like, in their early 20s, no pregnancy history, nothing. So could it still be an issue with that complex?
The scientific answer is we don't know.
Of course. We barely figure it out with pregnancy. Forget the people that haven't even gotten pregnant yet.
But, then we start to think about genetics and connective tissue quality, chronic constipation, chronic coughing. So if somebody has a lung condition, so let's think about like emphysema or, and I don't mean you get sick with a cold for 7 days and you're coughing a lot. Somebody that has a chronic cough, so a lot of pressure down on those structures, what their activities are. You mentioned Dr. Christina Previtt. She had a wonderful clinical commentary in the POPG journal. Yes, I say that right, POGP.
Yes.
Talking about breathing and bracing strategies. If somebody hasn't been taught those, they might be putting excessive pressure on their pelvic floor during certain activities. And so I think it is plausible that there could be injury or insult to any of those structures in somebody that is nulliparous, not a levator avulsion, which means that the muscle has completely detached from the bone. But think about other grades of muscles. We can think about a grade 1 hamstring strain, and we can think about a hamstring avulsion. And they're both injuries to the tissue, but they're occurring across a spectrum. But that doesn't mean that somebody with a grade 1 hamstring strain doesn't have symptoms and that they don't need rehabilitation to help them guide back to activity.
Right. No, and this particular one I'm thinking was, she was a D1 collegiate runner with a lot of things going on, and unfortunately got to me literally the day before her surgery. But it just definitely makes you look at the whole situation of prolapse in an entirely different light. It's like, yes, vaginal birth, carrying a baby can be part of it, but are there things in play that kind of set us up even before we get to that parity conversation?
Absolutely. And Carrie, I'd like to take a step back. I know you've talked about it before, but if this is the first episode that somebody's listened to, we're talking about prolapse. I'd like to take a second to define what prolapse is.
Please.
And it's important to define because the definition has changed over time. So has the grading criteria. But it does appear that the International Continence Society, I think it's the International Urogynecologic Society, but all of their terminology is starting to be very similar.
Yes.
And that prolapse is the anatomical descent of either the anterior, which means front, or the posterior, which means back, vaginal wall, or descent of the cervix, the uterus. If you've had a hysterectomy, you can have what's called a cuff, so the cuff can drop down. So anatomical descent of any of those structures to or beyond the level of the hymen, with concordant report of symptoms, or with mechanical problems or distress that may not be symptomatic. So what I mean by that is somebody might have a very significant, let's say, uterine prolapse, where the uterus is outside of the body.
Yep.
They may not report symptoms, or it might not bother them. They might say, I just push it back in. But that can be medically dangerous because that tissue is not designed to be outside of the body. It's a mucous membrane. And so if it dries out, that can cause cracking and bleeding and infection. And so in that case, surgery is warranted because we want to protect that individual. So that's what, that second part of the definition, that you have this descent in conjunction with symptoms or, a big medical problem.
Yep.
And the reason why this definition is important is the old definition, and it's still used, talks about stages of stages 1 through 4. And stages 1 and 2 were anatomical descent that is now considered to be just kind of normal. Descent. I don't want to say laxity. That has a very negative connotation. It's not laxity, but it's just kind of like normal changes. We're moving bodies. We're upright. There is pressure on things. We age, and so I'm happy to see that is starting to come out of the conversation, and we're not pathologizing something that's completely normal.
I think that's a really good point, because how many, and I'm sure you've seen this, patients come to you, had no idea, aren't even symptomatic, and someone says to them just innocently, oh, you have a grade 1 prolapse, or oh, you have a grade 2 prolapse. And now all of a sudden, that's all they see, that's all they feel, that's all they're aware of. And literally before somebody said anything, completely asymptomatic. And so I love that you've normalized that. And then also the clear delineation that we have moved on from when you and I had kind of first started in this, where you would have people that you'd examine them in every position possible. You don't see any, mechanical difference. You don't see it, in a different place, space, whatever, but they're very aware of symptoms, versus that client that literally the organ is outside of their body. The only symptoms they have is they have to shove it back up in because it's come out and it's chafing on their underwear. That we didn't have that delineation, even 5-10 years ago, I don't think. So I do think it's really important to see that now being translated into kind of some of this clear terminology and clear awareness, because it was really hard to kind of navigate those two things clinically for a long time.
And I think the beautiful thing about physical therapy is that we know that we can help with symptoms for prolapse. And when I say we know, it has been established in the literature. It's not that Carrie and Jenny know that we can do this. Yes. And then we also have evidence to show that if we go back to the staging, that for lower grade prolapses, physical therapy can actually change the grading of the prolapse. That is not true for the more significant prolapses. So that grade 3 or 4, which that would translate to what is now the definition of prolapse. But even in those more significant cases, PT can still help with symptom management. Yeah. And so I think as physical therapists, it is our ethical obligation to patients to make that perfectly clear, and to encourage patients and let them know, yes, I can absolutely help you with these things, without making unfounded claims that I can fix your prolapse. I have a problem. Susan Clinton was one of my mentors. And so I have a problem with she's fantastic, but this, the fixer mentality, that's not really the mentality that I grew up with as a PT. And so I think sometimes we overpromise to patients on things that we actually can't deliver on. And there's a mismatch between what the patient expects and what the patient hears, what we expect and what we tell the patient. And when there's that mismatch, I think that's where we get disappointment sometimes from both the patient and the clinician.
Yeah, I think that you're totally spot on. And I'll pull in, we were chatting a little bit before we hit record about kind of the role of social media in a lot of this stuff. And it's a blessing and a curse because we have far more awareness. I think our profession's done a really nice job of getting more education and awareness. But we do have people that are making unfounded promises. And I know I have shifted gears a bit in how I do subjective line of questioning to just get a better understanding of what people's expectations are when they come in and like what their goals are and what they've, what have you been told about your prolapse? How do you understand your prolapse? Because I need to understand where they are and if there's a gap between where they are and where they need to be. And if we don't connect, I'm going to have somebody that is like, they're not feeling fulfilled or they're not kind of going to be in line with the plan that we're working on together. So knowing that you're a little bit on social, but I probably more as a consumer, but like, what are some thoughts as a researcher kind of seeing this stuff that's out there, even from our own professionals?
It's a double-edged sword.
Yeah.
I am very encouraged that more and more people are aware of their pelvic health, of pelvic health physical therapy, of pelvic health occupational therapy, of all the things in the pelvic health space. But I look at some accounts where they say, well, this is, if you do these exercises, you're bulletproofing your pelvic floor for birth, or here's my birth prep exercises, and they're just doing 5 random exercises.
Yeah.
And sure, during pregnancy, we know there are musculoskeletal changes. We do know that the exercises that I see in these short video clips can potentially help those muscles, but there are probably hundreds of other exercises that you could do as well. And so the reason why I see that is somewhat problematic, not because the exercises are problematic or not because those individuals have ill intent, they are providing something to the consumer, but it's then the consumer thinking these are the only things I should do. And then when I see individuals as patients, well, I saw this on social media, then I am having to do a lot of extra education. And sometimes it's not enough to get people to understand like why there are other things we should be doing, why there are other things we should consider, or how we should incorporate those things into a broader, treatment plan. Yep. The other thing, that you see kind of more in comments is the difficulty that some clinicians, and I would put myself in this boat prior to doing the PhD program, in interpreting what studies say. And I think one of the barriers is the paywall, where you can only see the abstract, and that is not the clinician's fault. Yeah. That is kind of the publishing industry's issue that needs to be dealt with at some point so that we can disseminate information to everybody and anybody that needs it.
Yep.
But when you have access and you just read the abstract or you just see what you want to see, you're missing the nuance of certain things. And I think it's the nuance that's important. Yep. So I'm cautiously optimistic and cautiously pessimistic about the use of social media in this space.
Yeah. No, and I think there's 2 things there. Apparently your mailman's there, but
I'm sorry. Yoda really wanted to be on your podcast.
I love that name for a dog. That's amazing. No, I think there's a couple things there. One, I think it's always sort of been a downfall of clinicians to just read the abstract. Some of that I think is how we're taught. Research in PT school isn't like incredibly functional. And it's hard. And you've done a really nice job. I know you did some stuff with POGP about reading research and interpreting and that sort of thing. So I think that's always been a little bit of a downfall because it can be scary to understand things and in time. Also the paywall. Here's the other thing that I've also learned how to do. Just email the author. And when you kind of understand that you guys get nothing for, financially, because I always like, oh, well, they're going to want us to buy the journal because they get something from it. No, you don't. So if I don't have access, and I have a weird convoluted relationship with my university now, because they will only let you have virtual library access when you currently have an active course. And so as adjunct, that fluctuates. So that's made my relationship with literature a little less convenient. I just email the author, and people have been so gracious about sending stuff back, because I don't want to just take, the summary from the abstract. Like I want to dive in a little bit. I want to read a little bit more. I think if you get used to doing that and not get so freaked out about the paywall, and because you guys really want to share your data. And that's where I think that it's been such a joy to have researchers like you on the podcast, and to highlight research on social media and be like, hey, this can be accessible, and you guys are the best ones to talk about it and get that information out there. So thank you for kind of diving into that piece a little bit. So now I want to kind of circle back to the original article about some of the stuff that you kind of like. Can we pull some of those tidbits out? And then also maybe back to some of the comments from the reel that I posted, where some people are like, oh, no. And you're like, no, but this is what the research says.
Thank you for keeping us on track, Carrie. I am going to focus on what we can do in physical therapy.
Love it.
This paper was published in the American Journal of Obstetrics and Gynecology. And so some of the things that were recommended were geared towards physicians. As physical therapists, we don't perform deliveries. No. And so, one of the things was, if possible, converting an occiput posterior to occiput anterior. As a physical therapist, I'm not going to do that because I'm not birthing the baby. So one of the recommendations was to teach women how to relax their pelvic floors so they're not pushing against a contracted muscle. And there was a table in the paper that talked about kind of the 3 plausible mechanisms of levator avulsion injury. Mm-hmm. And it's really been shown that it's the overstretching of the muscle and not the compression or the neuropathy that causes the levator avulsion. Mm-hmm. And so by teaching women how to relax their muscles while they're pushing can really help it's not a prevention strategy, it's a risk reduction strategy. So that's one of the key differentiators. And so one of the things that is commonly done in physical therapy that can be very helpful during pregnancy is to work with a provider to make sure that you are able to relax and lengthen your pelvic floor. This is not to be confused with the viscoelastic nature of the lower birth canal tissues. What the heck does that mean? I'm going to explain it. So we have muscle relaxation that you are in voluntary control of. Then you have the tissue properties themselves. So you cannot control your viscoelasticity. That is genetic. And what that is, it's the stretchiness of your tissue. So I think if we kind of break it into its 2 parts, kind of the visco and then elastic, I think about viscosity as the resistance to flow. Mm-hmm. And I think honey is the best example to think of. If honey is really cold, you take it out of your refrigerator, you try to tip it upside down and put it on some toast. It's not coming out of there. You have to squeeze really hard. You're fighting with it. There's a lot of resistance to flow. Mm-hmm. Versus if you take that same honey, put it in the microwave, heat it up, well, now it flows a lot better. Mm. And the honey itself hasn't inherently changed, but as you warmed it, the properties of that honey change so that it can flow more easily. Then we can also think how elastic something is. And I like to think about springs. So think about a slinky versus like a weight clip. Slinkies you can play with in your hands. They move really easily. They go back and forth. You barely have to use any force. Versus some weight clips, you really have to squeeze on them to get them to open. And so if you combine those things together, kind of how easily it is to move something versus the inherent, how easily does something flow, that's what makes up the stretchiness of the lower birth canal tissues that are not just the muscles, but like the vaginal wall itself, the connective tissue. And so during birth, the viscoelasticity of the tissue is what allows it to stretch up to 300% of its normal size. In most women, that happens very easily. You don't train for it. There's no way to birth prep for it. So physical therapy can't affect that at all. We actually, maybe perineal compresses and heat can potentially affect that, but there are studies that are looking into that, but we still don't even really know that for a definitive fact.
Yeah.
But there are some women whose tissues are just very stiff. Yeah. And they aren't very stretchy. And so as dilation occurs, it takes a lot of force for their tissues to stretch. And even if the muscles are relaxing, their tissues are just too stiff. Mm-hmm. And so one of the things that does not exist right now is we have no way to predict who's going to have a birth injury. We have no way to predict, okay, A, what are all the factors we need to think about? And then B, how do we measure those? But, and very exciting, we talk about it in the paper, there's been work here done by numerous people where we think about combining something called a capacity demand analysis, which is doing measurements of the pelvic size, kind of the pelvic outlet size, and then the fetal head to say, okay, can this head go through this pelvis? Mm-hmm. And I love the analogy that we used in the paper of a bridge and a truck. Yes. If the bridge is too low, the truck's not going underneath the bridge.
Right.
Right. And then the other thing is the ability, there's an ongoing clinical trial right now called the EASE trial to see, can we pre-dilate the tissues to see how stretchy or not stretchy are the tissues. And then is there some way that we can combine those things, maybe in like a 37 or 38 week assessment, to then say, okay, we're doing measures A, B, and C. Here's our risk stratifications. If your score is below this, then you are at a higher risk for having this injury, in which case, depending on a lot of patient-specific factors, the doctor might have a conversation about a planned C-section. These things don't exist yet, but they're at least being talked about and thought about. And there are some studies underway that are trying to look at these things.
I love that line of thought, to use data ahead of time to help us make more knowledgeable decisions, because the stuff that I'm seeing kind of on either end of the spectrum, one is you have, I'm thinking specifically, I mentioned to you earlier, like Jocelyn Fitzgerald, who's, she's been on the podcast before. She's a urogynecologist in Pittsburgh, was very vocal this winter about, moms need to know, birthing people need to understand that there's inherent risks to pregnancy. And I get that. But to me, it's also a little fear mongering, like kind of what we said earlier, like the only thing you can do to totally be sure that you prevent this is not have a kid. And that's obviously not the plan if we're having this conversation. But then on the other side, I see providers in our own space saying, oh, well, I planned out my birth perfectly and I did everything just right and everything went well. And if you do exactly what I did, you can have that too, which is total bullshit for the exact reasons that you just said, that we've got the honey slinky, that's something that you walk in the door, thanks mom and dad, with, and we don't have a way to assess that yet. But when we do, you don't have to take people's word for it. We'll have some individual data to say, hey, these are the potential factors that we're going to run into with a delivery. Knowing this, let's set you up for the best possible birth situation that we don't put you at risk for injury, which I have to assume this is coming. And then with that also needs to come equity to make sure that this is accessible for, all socioeconomic status, geography, kind of all that good stuff. But I love that that's a conversation that's being had, because I don't particularly care for the alternatives.
I would agree. And then I want to highlight one of my colleagues. She's a postdoctoral fellow. She got her PhD in mechanical engineering last year, Dr. Bariana Masseling. So for all of you out there somebody you'll definitely want to follow her research. But her dissertation work found that there's a 7-fold difference in the viscoelasticity of the birth canal in women that are delivering vaginally. So
Ooh.
there's a 7-fold variation across birthing people. And that's nothing we can change with physical therapy.
Wow.
That's kind of like, I think, to my dissertation and thinking about dysplasia and hip structure, we all have different hip structure and different structure of the femur or the long bone or of the acetabulum and the socket. And just because there's variation doesn't mean it's bad.
Right.
But that means that we have to consider, okay, how are we teaching somebody to squat? If their structure kind of lends them to being more turned in or anteverted, then maybe coaching them to squat with their feet parallel might be problematic for them. And so I think her work was so important because it's saying, hey, there's a lot of variability in this property for delivery.
Mm-hmm.
And so now we need a way to measure that, like I said, and then to combine it into a pre-delivery assessment. And again, Dr. Masteling and then other phenomenal scientists are working on this. But it was really kind of the first in vivo data that we had measuring this.
That's so cool.
And she's an engineer. And so I think the other thing to consider, I'm not saying if you're a physical therapist, you need to go out and find yourself an engineering friend to come into your practice. But really, my eyes were completely opened when I started working with engineers and the way that they thought about problems and the way in which they take measurement very seriously and how measurement matters. And I think sometimes in pelvic health, that is an area that we can continue to improve upon. And so then when I think back to the article, and for the therapist listening to this, it's like, well, what's something that I can do in my practice right now? You can use pop sticks to measure the genital hiatus length. And you could do that before pregnancy. You can do that after pregnancy, because we know that the larger that length is, the more likelihood that somebody is going to develop prolapse over the next 15 to 20 years. And so I think that's a very nice, easy, implementable thing that we can do in clinic right now.
That's great. And I love the actionability of that. And even if you don't have access to a pelvic floor PT and you're wondering, okay, how do I figure this out myself? Just think about it. The bigger the opening, the less the kind of the architectural support in that respect. And I women in STEM will save us all, by the way. So if you have daughters that are thinking about STEM, please encourage them, because they will save us. But I also think too, that brings out another wonderful point of, we are going to figure this out because of people coming at it from so many different angles. And that's, again, one of the things that I think I connect with you is you and I, I've got my longstanding hip history, you as well, are coming at these problems with a lot of different kind of points of view. And we can't, and this is my biggest concern, honestly, with people going straight into pelvic health, is if you are not considering the pelvic region from multiple angles, you're just going to miss the boat. We're just too we're just too complex in this wonderfully magnificent way that if you're only looking at it just as the pelvic floor is the queen of all things, like you're gonna miss out. There's too many other just really cool layers of stuff that make us so that we're gonna get this stuff figured out for sure.
Absolutely. And then on a very encouraging note, thinking about, okay, if I do have a birth injury, if I do develop prolapse, what are my options?
Yep.
And options are becoming more and more abundant, which is very exciting. So pelvic health physical therapy is absolutely one of the recommended interventions, especially for symptoms, for the management of prolapse, to help you to be able to perform your daily activities of daily living, caring for children, performing desired physical activity. Physical therapists are great people to help with that. Pessaries, which are basically orthotics for the pelvic floor. So think about maybe like an insert you'd put in your shoe, or some people have ankle braces. There are standard pessary sizes. If you were to get a pessary, traditionally fit by urogynecologists, some OBGYNs do it. And now in the United States, kind of in the past 2 years, it is coming into the scope of physical therapy practice. So if physical therapists are trained, there are some physical therapists that are fitting pessaries. They come in lots of different shapes. So that would be something that is not disposable. There are also disposable pessaries that kind of look like tampons. Poise Impressa or Uresta are two examples of those. But what I really want to highlight is Cosm, which is a company based out of Toronto, just got FDA clearance a couple weeks ago for the first personalized pessary in the United States with over 10 million combinations. And the reason why this is important is because some women want to try pessaries, they try them, and they fail the pessary. It doesn't really help their symptoms, or it just won't stay in. And the reason why is there's still standardized sizes and shapes. And so as we think about this era of personalized medicine, why would we not also personalize pessaries? So again, they just got FDA clearance in March. So I think, again, in the next 1 to 2 years, this is a very exciting symptom management opportunity for individuals with prolapse.
Yeah, no, it's such a cool time. I got trained maybe a year and a half ago in pessaries, and just having earlier access, like I would always delay it because it would take so freaking long to get somebody into a urogyn appointment, then have to go back for the fitting and then go back for the recheck. And if they went to somebody that wasn't great at it, then, or didn't give them a lot of alternatives, it just was this whole long ordeal. Now to have more over-the-counter options, being able to do fittings in the office and getting them to people quickly at a low cost, we're using them a lot sooner in postpartum. And I think heading off some of those patients that are symptomatic but don't necessarily have as big a mechanical problem or descent or things like that, and then actually having the conversation about weaning them off or only using them kind of situationally. So to have an option that is tailor-made, it just takes out all the subjectivity. It takes out and again, I'm sure there's going to be a cost to this initially, but like to take out the subjectivity, to take out you have somebody that does bad fittings or something like that. It just makes it really nice. So again, STEM will save us.
And then I can't forget, in kind of the treatment buffet, surgery is also an option that is, absolutely needed for more severe prolapses. And I think one of the things that I've appreciated in my position now, I have seen some prolapses that I just have never seen in my 10 years of clinical practice. And I think it's kind of appreciating that some of these very severe ones don't come to PT. Like and I think as PTs, if we're blinded to the fact that this severity exists, and we're like, well, everyone should just get PT. It's like, well, the reality is that no.
Agreed.
PT can be very beneficial for a lot of things. And I think you could argue that anybody could benefit from PT for any reason. But we have to think about the resource availability of the people that are using our services, whether that's financial, whether that's time, whether that's childcare availability, and then also the resources on the provider's end of, I only have so many hours in a day to see a patient. Who are the people that really need my help the most, that I can help the most, so we can make sure that we're getting those people in? Not to say that the other people don't deserve care. We need to see those too. But we're so backlogged in healthcare right now that this messaging that everybody should go to PT, I think, is making it worse for the people that really do need to be there. And so that's why in the paper, we really highlighted that if somebody, in kind of that 2 to 6 week postpartum period, the people that should be prioritized for physical therapy referral are the people that are having bothersome symptoms, that are not able to care for their children or perform their daily tasks, as opposed to somebody that says, I have a little bit of neck pain. Yes, that neck pain is valid. Yes, physical therapy can help with that. But, if I have 3 available spots in my day,
Yeah.
who are those services going to best serve? Then also thinking about how can we utilize apps and virtual care and other things to still serve the patient population, while also optimizing the care that we can provide to the people that are in front of us in our live patient care.
Yeah, no, and I've been very vocal about this, and I can now, not being the head of a professional association, I can have an opinion, that I don't agree that every postpartum person should see pelvic floor PT. I think exactly as you're saying, our expertise should be for those particular scenarios that, a trainer or, somebody like that can't handle, or some basic education. And that's why I've been, for so many years, put so much information out for free accessibility, helping people get connected to, people that have some background and able to help with that simple stuff. Cause sometimes it doesn't take that much. We should, I wish orthopedic PTs were a little bit more comfortable with pregnant and postpartum patients and, so freaked out about them. But the other thing I was thinking too, was with, talking about those patients that are definitely surgical cases. And I would love your opinion on this, because I don't know of any studies where we look at these prolapse surgeries and revision rates and things like that. I don't know of any studies that looked at if any issues were addressable prior. So I'm thinking of those clients that do have like pressure management issues or things like that that can be addressed, or constipation or things like that that can be addressed in a pre-op setting, that if they're not addressed, increase their risk for potential revision after surgery. I do think that there's a role for us in education, and maybe, places like Kaiser get it right where they do group therapy and things like that. But I was wondering your thoughts on, kind of our role in pre-op and post-op to address revision rates. I know we kind of went off the rails there, but.
Sure. So the studies that are out there kind of unfortunately show that adding pelvic health physical therapy before or after the surgery doesn't change things. It doesn't make it worse, but it doesn't make it better. Those are very few numbered studies. And I will say from a clinical perspective, I also believe that there is a role if you have chronic constipation, to use the example you gave, and then you have a surgery, then you go back to having chronic constipation. I don't know that I've seen any studies that say, oh, not learning how to have optimal toileting mechanics then caused a failure of a repair.
Yeah.
But we do know that if you have a levator avulsion, so about 19% of women that deliver, or people that deliver vaginally, will have the avulsion, that their prolapse recurrence rates after surgery were much higher. And so I would think for those people, especially, that trying to have optimal habits, whether that actually changes the outcome or not, we don't know. Right. But I have to imagine it's definitely not going to hurt anything. There are no adverse events. Worst case scenario is the status quo stays the same.
Right.
Education now, especially for toileting, if you just have a small problem, there's ample education from a lot of sources. It's kind of a pick the low-hanging fruit.
Yep.
Why not do it?
Yeah.
So that's exactly a little bit of what we have in the evidence and Jenny's personal opinion. So take that for what it is.
Which I love. Like, again, I do not have a mind for memorization, but I do have an ultimate respect for people that can dive into and remember all the minutia of the literature and be able to pull at it at a moment's notice. So thank you for being one of those people. Love it. All right. Any other big takeaways? Either for clinicians, postpartum providers, or even moms just trying to help sort of navigate this space a little bit as they're kind of looking at pregnancy or postpartum, things that either we should be thinking about or things that are potentially misnomers that we're seeing out there.
That's a great question, Carrie. And I'm going to answer. If you have the paper referring to the very last section, you and I were talking about it a little bit before we got on, but education is paramount, but also using, I think I saw somebody in your comments called it empathetic honesty or honest empathy, but birthing people have a right to know what risks exist, what options exist to mitigate or reduce those risks, and then what treatment options exist if something were to occur.
Yeah.
But there is also a way to deliver that education without, as you said, fear mongering.
Yeah.
And as a practitioner, that's something where I kind of say, I think I'll get the most bang for my buck if I really start to try to practice how do I educate without scaring.
Yeah.
And not only not scaring, but to actually empower birthing people to make choices that are best suited for their individual situation. And I think one of the problems with social media is and you alluded to it, is, well, my experience was this. And hearing people's experiences can be very, very validating for some people, but it can be very harmful for other people. And so as providers, I know we throw this term around a lot, but really using shared decision-making and education to come alongside people, using trauma-informed care principles. I know Christina Holland does a ton of work in this space, to really give people the information to make their own decisions. And if they need help kind of navigating that, then it can be our role to help them and not say, well, this is what I would do.
Right.
But, well, did you think about this? What does this look like in your life if it played out this way? If X happened, how would you feel about that? What would that look like for you and your family? So, in addition to teaching women how to relax their pelvic floors, which I think is very important and was demonstrated so in the article, I think this education and honest empathy and coming alongside this population is really, because we spend so much time with people, I think can be a very powerful tool.
Yeah, no, it absolutely. I in the past probably 4 or 5 years, I have had, and granted, in the DC area, we tend to have a lot of overeducated soon-to-be moms that want to prevent all the things and feel like we have control. And I can say that because I was one of those, laminated my birth plan, whole thing, so I feel like I have some ability to say that. So getting moms that want to come in even before they get pregnant, or, the second they get pregnant, they schedule the appointment, say, I want to do everything I can do to have the perfect birth. Or my personal favorite that gets me, and still a little dagger to my heart every time, is they come and say, well, of course I don't want a C-section. And most of them don't know I've had to. And I have to kind of brush that judgment away for a second and be like, okay, they just don't know what they don't know. But it's an opportunity that I have used to educate. And some of that is informed by my own experience, in that I did zero to prepare to understand a C-section. And granted, this was, 13 years ago, and there was a lot we didn't know then. But to hope for the best and plan for all the things, and just increase the awareness, and put them in contact with people that can help prepare if you have an option to, work with a doula or something like that. But the situations that I don't ever want somebody to walk into a delivery with, and sometimes this happens when people come in, it's like they make an appointment and they're like 38 weeks. Like, okay, we don't really have a lot of time here. Is they have this like plan written in stone that they have zero idea that there's so little, like there's, especially that late in the game, there's not a whole heck of a lot that we can do to kind of change their mind almost. So I love that you highlight, it's this shared alliance, it's this shared collaboration, and the line of questioning to be able to, well, how would you feel about this? Or what would you do in this situation? Instead of being like, and again, this is my internal dialogue, like, oh God, like, you don't even know the possibilities. And C-sections aren't that bad. And sometimes they're good. And that's why I'm also alive and my kid's alive too. So I think those are important conversations to have. I guess that's the summary.
You summarized it beautifully. And these are important conversations to have in PT clinics. Also important conversations to have in labor and delivery. And whether it's a PT or an RN, if somebody does come in with a laminated birth plan, instead of, it's interesting. I did this wonderful implicit bias training for pregnancy with an organization here and hoping to do some more work with them. But, in our heads, it's like, well, our job is to make sure that you stay alive. And for some women, we are not doing a very good job of that right now.
Right.
But, baby and mom, parent, alive and doing well, but not just brushing somebody off and using those same questions. If they bring in their birth plan, honoring and respecting, yes, let's talk about what's on here. But if these things were to not be able to happen, or this situation happened, how would you feel about that?
Yes.
What would you want us to do if this didn't happen? And that's really where the role of a doula can be incredibly helpful, because they can kind of help advocate for the birthing individual and kind of help talk through those decisions. But even though that process can be very fast sometimes, and the thought of having this conversation is daunting, to reduce implicit bias in the care that we provide to this population, this is the work that we need to do.
Yeah, no, 100%.
And I would emphasize that it's especially work that we need to do when caring for our Black and non-white patients.
Yes, absolutely. Absolutely. And doing it in a safe space. I think that's one thing that I completely miss. Oh, I don't know what the word for. I thought, and we did have a doula the first time around. And I'm so glad we had her, and she was incredibly helpful and was a midwife in the UK. And so she caught a lot of things and was quite helpful, even though, we ended up with the C. But you're not in sound mind and body when you're in that situation. And so when you have these discussions, good or bad, ahead of time, you've at least hashed it out. Like, I remember trying to negotiate with the OB, and because of course, like, it was the hospital that I worked at, and of course I ended up with a weekend guy that I didn't know. I went through everybody else and then got the guy I didn't know, and he's like, "Yeah, remember when I told you you could do whatever you want?" He's like, "That's over," and I'm like, "Wait, what?" Like, I'm still trying to negotiate with this guy, and it's like, "No, girl, like, time's over." But again, having those conversations of the what ifs. In a safe space where you feel like you're being heard, and it's a collaborative sort of effort, so you can kind of make these considerations. Because the thing that I really detest right now is this adversarial relationship, and I think it's only gotten worse. And I don't know the solution to it other than finding providers you trust, because you get, again, people on social being like, well, your doctor needs to be doing this, and this is a bad test, and this is a good test, and I love that there's people out there. I do not know her actual name, but her handle is like Babies Over 35. She's an OBGYN, that she does really good stitches about kind of taking these things and putting it in context.
Shannon Clark.
Yes, thank you. Yes, thank you. She's amazing at saying, hey, this is legit and this is not. We have to have these conversations ahead of time, because when you're in that scenario, you don't have time to negotiate. And sometimes it is life or death. And it's very hard, having kind of navigated those situations myself, to reconcile it on the other side and question whether you did the right thing or whether you could have done it better. And that's a hard process to have to mourn when you didn't get the birth that you had planned on or laminated or whatever. So all good conversations.
And I think when we instead of seeking to prove something, more taking the attitude of seeking to understand how the patient, the birthing individual, is feeling, what their preferences are, and kind of questioning ourselves, okay, is this my bias that I'm putting onto this patient? And did they make a facial expression and I interpreted a certain way, even though that might not be what they meant at all? Like, can I take a step back from that and then ask, a thoughtful question? I noticed that you did this. How are you feeling? Are you feeling scared? Are you feeling worried? Again, just kind of coming from a place of seeking to understand instead of seeking from a place to just tell people how much we know.
Yes. And we like to do that, don't we?
We do. Carrie, I'll be the first to admit that I am guilty of this. I think the more seasoned I've gotten, the less I do it, because like the famous quote says, the more I learn, the more I realize how little I know. but I cannot be the pot calling the kettle, or I would be the pot calling the kettle black if I didn't admit that I still do this.
Mm-hmm.
And just trying to recognize and trying to do better. But I think it's something that we can all work on.
Yeah. I mean, asking questions to clarify and to understand, seek to understand, like you said. And we all learn what assuming does, right? So I think we learn so much more and understand our patients so much more when you ask to clarify and to understand. So thank you for I think that's sage advice, regardless of what you practice, or, I think that's just sage advice for interacting with other humans. So thank you for that lovely reminder. Anything else? Any last big things to pull out before we wrap up here?
I don't think so. I guess I would just say to the clinicians listening to this, thank you for the work that you're doing to serve the patients that you serve. Continue to strive to be curious, to seek to understand, whether that's a patient's story or what evidence is available. And then thank you to all of the patients that are listening to this for honoring us with your trust to care for you in a very vulnerable time. It's not lost on us.
Yeah, no, I think that's great. It's so sweet to see how much you've grown up. I don't mean to be like mothering or anything, but I'm like, no, it's just, I'm so proud. I'm so proud.
Well, thank you.
All right. At the end of every episode, we ask a bunch of questions. We're going to adapt them a little bit for you today. Book that you're reading or podcast that you're listening to right now.
Ooh, great question. I'm reading a book on statistics right now.
Of course you are. And that's why I love you, because I could never do that.
I also just finished reading a book on how to negotiate, and the name of the book is eluding me right now, but it was a very good book. Not anything to do with anything I use in patient care, but just very interesting.
Got it. Okay. Do you ever read fiction or no?
I do. I also just finished the second book of Wheel of Time. Whew, that was an investment.
Is that the one Christina's reading? I feel like she's stuck in okay. I get all these these, is it like a fantastical sort of thing or no?
It is. So, okay. Carrie, something to know about me is I'm an avid reader, but I'm also a very proud avid TV watcher. I know a lot of people are embarrassed about that, but I love TV. And so The Wheel of Time was a series on Amazon Prime. And so I was introduced to it first because I watched it. But then my best friend in Oklahoma, who is my 74-year-old neighbor, her husband was a big Wheel of Time fan and owned all 14 books in the series and had 3 copies of it. So when I left Oklahoma, she gifted me with the entire series of Wheel of Time. So in 3 years, I've read 2 of the books, which I usually read 2 or 3 books a month. So if that says anything about how difficult these books are to get through, they're a commitment.
Okay. All right. I'll put that on my to-do list for a time I have a little bit more time.
Yeah.
All right. Favorite activity since becoming a researcher? Statistics.
Maybe not favorite, but the most interesting thing that I get to do now that I never thought I would get to do is I get to help harvest sheep pelvises from sheep that have recently been euthanized. So I go into the sheep OR, and that has been a very interesting experience.
You go into the sheep OR. Is this a vet school? Is this like
it's at the hospital?
You have a sheep OR.
Well, I know they have pigs in there as well. I'm not sure if they have other animals, but it's for research. It's in a different part of the hospital. But it's been trying to appreciate, and of course, because my work on the hips, I'm looking at their femurs, like, oh, their femoral heads are so tiny, and their acetabulum are shaped so interestingly, and just like, how does a quadruped's anatomy look different than a biped's anatomy? That's so crazy. It might not be my favorite activity, but it's probably one of the most interesting things that I've gotten to do since starting this fellowship.
That is the best answer that we've had in like 2.5 years. That's so cool. Oh my gosh, I had no idea. All right. All right, we're going to take a hard left here. back into kind of your clinical and research mind out of the the sheep OR. One piece of advice for new moms.
Give yourself grace.
I think maybe once in over 100 episodes we've had a different answer. So it's nice to see that we're all a little consistent there.
Yeah.
All right, you mentioned the other researcher earlier, and I'm going to have you say her name again so I can Google stalk her. But who's somebody kind of in this space that we should know about that we don't already know?
So I'll give you two. I'll repeat. So Dr. Mariana Masteling is one.
Mhm.
And then Dr. Fernanda Pipitone. They're
Yes.
both authors on the expert review paper.
Yep.
She is a urogynecologist in Brazil.
Mhm.
She's getting ready to defend her PhD sometime this year, I believe.
Okay.
But those are two people that I would be watching.
That's super cool. No, thank you for that. Because I just, it's one of those things that like your friend knows a friend knows a friend, and then it just, the world is so much smaller. But I love, getting like-minded kind of voices and attitudes and things like that. So perfect. All right. And then last one for you. What does it mean to you to be a researcher for active moms in postpartum?
It really feels like an honor to be able to take clinically meaningful questions and to try to solve them. And so to me, I feel like the holder of responsibility to help active moms in the postpartum period, both as a clinician, but I only treat patients once a week. One of the reasons I got into research is I felt like I might be able to help more people in this capacity. Because if I could do research to improve mechanistic understanding of some of these things, such as prolapse, so then we could then target potential interventions, develop new interventions and diagnostics, for then the randomized controlled trials to see what actually works. I think the ability to potentially help people is really an honor and what really drives my passion and what it means to be a researcher in this space.
I love it. And so thankful for people like you to recognize the need and then put yourself forward to meet that need and kind of and share it with others. That's the other thing too. It's one thing to kind of have, I don't know what the heck's going on here. It's one thing to have, I think, that desire to have questions answered, but it's another to step up and be like, you know what, I'm going to do it, and I'm going to, bring other people along for the ride and share that information and make sure that it goes back to my profession and helps not only our profession move forward, but also improves care. That full circle sort of thing. You don't see it a lot, and I'm so glad that there's more women like you that are stepping up and showing that it can be done to be in research and clinical care and kind of pull it all together. So thank you for all that you do and all that you share and coming on and sharing with us today.
Thank you so much for having me, Carrie. It was an absolute pleasure.
Awesome. If you want to know more about Jenny, you can find her on Instagram at jen.lacrosse. And hit her up. She'll send you her paper.
I absolutely will.
Awesome. Thank you so much for being on the podcast. And I'm excited to see more work from you in the future.
Thanks, Carrie.
Did you enjoy the podcast? If so, leave us a 5-star review on iTunes and tell a friend to do the same. Are you a postpartum mom or postpartum pro wanting to know more about getting back to running after baby? Check out all my free goodies on carriepagliano.com. This podcast represents the opinions of Dr. Carrie Pagliano and her guests to the show. The content should not be taken as medical advice and is for entertainment purposes only. Always consult your healthcare professional for any medical questions.